Good morning, everyone. I'm Mary Margaret Oliver. I'm chair of the Workforce and Systems Development Subcommittee of the Behavioral Health Reform and Innovation Commission, and we have called this subcommittee meeting today. Our agenda is posted on our online link to the House media offices, and most of the materials that we will be offering today, some of which we have copies here in the room, but others will be posted by House media if you'll email that document to me and to Camille Taylor, and we will give you her complete email a couple of times during this presentation. Thank you for your attendance. We have people in person and on Zoom, and we have an agenda, and there's some copies of the agenda down there. I would like to start with a little bit of an update of where I think we are, we being the Behavioral Health Commission and all the subcommittees who are working, and give you what I think might be a timetable between now and Christmas, because we're going to be very busy. Kevin Tanner has met with all the subcommittee chairs by Zoom or in person, and he has given us a timetable that he will have a full behavioral health commission meeting either the week before Thanksgiving or the week after Thanksgiving, and he will ask all of the 4 subcommittee chairs at that time to make presentations. I consider the presentation that our subcommittee will be preparing will be sort of a preliminary statement of our recommendations. So between now and whenever this committee meeting is set, whether it's around November 16th or a week after around November 20 after Thanksgiving, the subcommittee our subcommittee will be meeting probably by Zoom at that time to have a discussion and a completion of some of the questions that are raised through this is our 3rd subcommittee through the summer. I think that we will try to come at that time together with a list of recommendations. And when we present our recommendations to the full Behavioral Commission, we'll then get more specific directions from Commissioner Tanner as to timelines, as to preparation of a written report. When a written report is produced, I think sometime in perhaps the first half of December, then we'll have a lot of discussions, most importantly with Speaker David Ralston, who's been one of the significant leaders of this effort, and all the other folks that have been so generous with their time and so specific in helping us in so many different ways. So we're going to be very busy as we move forward with the recommendations of all the subcommittees and with the completion of a presentation of subcommittee recommendations and development of a report. And I know that all of you, based on the generosity of the time you've offered thus far, will be involved in all that. Before we go further, I think it'd be good if we introduce ourselves who are here in person. Dr. Sally Koch from Middle Georgia is in Ireland today with students very envious of that activity. So the committee members who are here, I'll begin to my right. If you would like to introduce yourself, please.
Hello, my name is Cindy Levi. I am the CEO for Avita Community Partners. I'm representing the Georgia Association of Community Service Boards and the safety net providers across the state. Thank you.
Thank you. Dr. Serban, would you like to introduce
yourself?
Good
morning.
Please?
This is Nicoleta Serban, professor at Georgia Tech, Industrial System Engineering. Mainly my role in Georgia Tech is doing research and teaching.
Thank you. To my left is Camille Taylor from House Research, and she's going to be, not House Research, House Media Service. So she's going to be helping me with all of the machinery and posting and links and questions afterwards that you may have about obtaining document or this or that. She can probably help you most. So thank you. I'm going to ask, in relation to the other subcommittees, I do want you to know that I've been following up on a number of the different matters we have discussed, and particularly in relation, just to give you a little report on the data collection bill legislation we discussed last committee meeting. I have talked with Justice Boggs and also with the staffing folks that are working with him in a specific contract he has with the National Council of Legislators to work on what they're calling the Familiar Faces database. They have selected 9 different areas of Georgia that are working on a deep dive into data collection in the law enforcement arena. And I know that as we move forward that we will be talking about our rewrite of 374 in connection with them to make sure we're coordinating what they're learning from their data and what we might see as our goals in relation to a data collection legislation. I also have talked with Senator Blake Tillery, who was the primary sponsor of that bill as it moved forward to the through the Senate and to the House, and coordinating with him. And Elizabeth Holcomb and I have talked specifically. She is with the Grant Thomas Governor's Office of Health Strategy. She's the one who presented to us about how we will make a new draft available for subcommittee's consideration and also to share it with stakeholders as part of our probable discussion about our recommendations. I also have been in touch with Justice Boggs in relation to some other issues about the AOT program and co-responder program, and we will be following up on that. So we are beginning to, as informally, share some of the discussions that we're having in our individual subcommittee, moving towards preparation of a complete report. I'm going to call on now Melissa Haberlin and Leslie Kelly to come forward to discuss their paper on issues relating to foreign license holders. As they move forward, I'd also like to tell you about a very helpful and interesting conversation I've been having with Gwen Skinner, who you know is Executive Director of Developmnt. Gwen Skinner has, and Devereaux nationally, has used the federal visa law to acquire H-1B healthcare workers for Devereaux. They have, that is a federal program. We hear about that H-1B program most significantly in terms of farm workers. And I have, in a little bit of conversations, both with farmers and with lawyers representing farm workers, have learned about the logistics of that program and the protections of that program, but it is also used for healthcare workers. And Devereaux is now using H-1B employees pursuant to that specific federal process of statutes and employed on their campus now. I think it is a part of what we might consider just to understand the extent to which it's available for a trained workforce to come into Georgia on a limited basis and a supervised basis where there's a clear path for filling the slots that we know are open. It's also interesting, Gwen told me that these folks are being recruited for daily service provider help. And those folks in Georgia's have a GED or a less than college graduate, but for the visa H-1B program for those positions, they are asking people to apply only if they have a college graduate degree from what country they're coming from. So I just wanted to throw that piece in. I don't think it's in your paper, but if it is in your paper, you'll expand on it. And who would like to go first? Thank you. And we are going to ask you first to introduce yourself and just confirm that our microphone is up, and then you'll tell us where your paper is that people can read.
And Policy Director at Voices for Georgia's Children, and I'm here with a team of colleagues that I'd like for them to introduce themselves as well.
Thank you.
Good morning. My name is Belize Urbina. I am CEO and co-founder of Ser Familia. We provide services, mental health services to Latinos throughout Metro Atlanta.
Hi, my name is Leslie Kelly. I'm a senior policy analyst with Voices for Georgia's Children.
Thank you, ladies.
Can we start with the first slide?
Just 1 moment, who's pulling it up?
So to provide a little bit of context, over the last couple of months, Voices for Georgia's Children has been doing some research into state policy and practice that would help to better leverage foreign-trained behavioral health providers in our own workforce. And so we can start with the first slide. So here, what you see really is some of the demographic shifting that has happened in our state over the last 10 years. The main points from this chart being that the Hispanic and Asian populations in Georgia have grown at much faster rates than the white population in the state. And so when we think about behavioral health providers, we want to keep that sort of shifting demographic in mind when we think about who we need to be providing the behavioral health services to the folks in our state. Next slide. So we know that it's hard to get demographic data on our provider population in Georgia, and we were so glad that in HB 1013 that there was a piece in there to collect and publish better demographic data on our licensed clinicians in the state. But so what we have here is what we could find on psychologists in the nation. And what you see is a comparison of the workforce population demographically to the national population. And what that shows you is that nationally, there is an overrepresentation of white practitioners compared to Hispanic, Black, and Asian. Next slide. What we also wanted to bring up to just set the context is that, of course, we all know that there are healthcare shortages in all different healthcare provider types. What we see in Georgia over the last 10 years was that while we had an increase in population growth, the increase in our nursing population did not grow at the same rate as the general population. So that's a problem. There's also just generally been a downward trend in the prevalence of all practitioner types. What we also saw is prior to COVID-19, behavioral health practitioners experience extremely high rates of burnout. And that can absolutely lead to someone leaving the profession. And then what we saw through the COVID-19 pandemic is all healthcare provider types, behavioral health in particular, but also nurses and other general practitioners facing extreme exhaustion and burnout and choosing to leave the profession. So next slide. I'm going to kick it to Belisa to provide a little additional context and deep dive into the Hispanic needs.
Sure. According to the CDC, Hispanic youth in Georgia have more instances of feeling sad or hopeless to the point with enough severity that would hamper their normally activities. That numbers goes up to 50% of Latina girls in our state. That number is much higher than any other youth from any other race or ethnicity in Georgia, and it's one of the highest in the nation. So we had some issues that we were seeing before the pandemic. The pandemic has only exacerbated what we were already seeing. We are seeing much higher rates of severe depression and anxiety, double the number of domestic violence incidents, and most of these incidents are witnessed by children. So we have multiple victims, in each incident. We're also seeing 231% more cases of child physical abuse and child sexual abuse. So that is consistent with what DFACS agencies are seeing across the state. Normally, people that speak a second language or have a native language that is not English, even though they might be fluent in English, in a moment of trauma, they are going to revert to that native language, and they're going to be unable to express, the trauma, in English. They will need to express it in their native language. Next slide. So we have, I know that this slide is pretty busy, it has a lot of content, but, we have about 700,000 Latinos, Hispanics meaning people that speak Spanish, in Metro Atlanta. But the Atlanta Regional Commission is telling us that number is going to be to 1.75 million in the next 20 years or so. So certainly the number of clinicians, the need for clinicians with the rates that I just described is going to skyrocket. We normally try to keep the pulse on the number of clinicians that are culturally and linguistic proficient to serve Hispanics. And normally the number that we come up with is between 100 and 125 for the whole state. So in reality, we need to create that capacity. Also, Georgia requires more supervised hours than almost any other state in the Southeast for professional counseling licensure. So, also, we have to acknowledge that many times you have people that graduate with their masters, but because they are coming from minority communities, that there's not historic wealth or support, they are unable to complete the licensing process. And I have met many people that have their masters, but they have been unable to complete their licensing process.
Next slide, please. So when looking at the licensing rules and regulations in Georgia, particularly for behavioral healthcare workers, I looked at 4 different boards. You can see them on the slide. And what I found was for counseling, social work, marriage and family therapists, there is no way for a foreign trained professional to become licensed in the state of Georgia without essentially starting over with their education and any kind of supervision. Nursing is different. If you are a registered nurse in a different country, you can simply show proof of education, experience, and take the NCLEX, and that will allow you to be licensed as a registered nurse in Georgia. For some more advanced nursing degrees, such as APRN or psychiatric mental health board certified registered nurse, you do need additional education and supervision. Your education may be accredited, but that is subject to the rules of, I believe, about 4 different accreditation agencies, and which limit programs in very limited foreign countries. For psychologists, there is no real pathway to licensure in Georgia if they are foreign educated. The only real way to do that is if they are licensed in another state, that they may apply for licensure through endorsement in the state of Georgia. Physicians, they may submit proof of their foreign education, and that can be accredited in Georgia. The issue is whether or not their supervision, in other words, their residency, will be accredited in Georgia. And that is, again, up to one of 4 accreditation agencies that only accredit programs in 5 different countries. So again, very limited. So after reviewing the licensing rules and regulations in Georgia, we identified the following major barriers to licensing, which are limited or no recognition of foreign education, no recognition of practical experience gained in a foreign setting, and issues navigating a complicated licensure process. Next slide. So once I looked at the licensure rules, we did a 50-state scan to see what other states were doing to remove barriers to licensing for foreign trained health professionals. And this is inclusive of not only mental health professionals, but also just health professionals in general. 3 of the policies that stood out were temporary licensure for graduates working to complete their full licensure process. This is being done in Colorado, Massachusetts, and Missouri, where they have issued temporary licenses to international medical school graduates and foreign trained nurses. And also in Missouri, they established licensure as an assistant physician for international medical school graduates there. The second major example is defined pathways for foreign trained healthcare professionals. This is similar to what Georgia currently has for registered nurses. And in Vermont, they have a foreign credentialing rule, which creates a pathway for foreign trained professionals by using credit evaluation services to accredit education and experience outside of, the typical accreditation agencies that Georgia uses. Then another example is a task force to explore solutions specific to Georgia for healthcare professionals. Minnesota, Massachusetts, and Vermont have all done this. Their task forces have been comprised of a broad array of diverse stakeholders and have done really in-depth, multi-year studies into how to remove barriers for foreign trained professionals. Next slide. So we propose the following recommendations to help Georgia reduce licensing barriers for foreign trained health professionals. Again, when we were originally looking at this, we're concentrating on behavioral health professionals, but we also saw an opportunity to make recommendations for all foreign trained health professionals since there's such a need. The first recommendation is to create a subcommittee of Healthcare Workforce Commission to identify ways to integrate foreign trained health professionals into Georgia's healthcare workforce. This could be built on the Health Study Committee on innovative ways to maximize global talent. And again, building off of that, we'd like to engage a wider range of stakeholders and have a more thorough review of the current policy and barriers so that they can make state-specific recommendations. The second recommendation is to create a specific licensure pathway for foreign trained health professionals who are licensed in other countries. Again, this is similar to what we currently have for RNs, and we could do this by including the use of credential evaluation services to accredit foreign education and supervised experience, again, similar to the example in Vermont. And the last recommendation is to allow the issuance of temporary licenses while foreign trained health professionals work on meeting full licensure requirements. This would allow those seeking full licensure to actually be able to work and earn an income to support themselves and their families, which tends to be a barrier for those who are foreign trained seeking licenses. And then Sarah Familia, next slide, sorry, had some recommendations as well. They recommended creating funding opportunities to allow nonprofits and other agencies to provide supervised hours at no cost to culturally and linguistically diverse graduates who are working towards licensing. Again, this goes back to the costs associated with getting supervision and being able to earn an income at the same time. And the last recommendation is to assist with costs associated with relocation and licensure for a culturally and linguistically diverse healthcare workers. Again, we would like to be able to attract foreign trained workers or those that are just culturally and linguistically diverse from other states and other countries such as Puerto Rico that have similar accreditation requirements. I think that's the end. Yes, and then if you need to contact any of us, all of our contact information is up there.
Thank you very much. For benefit of y'all and people in the audience and folks online, I received a letter this morning from the National Association of Social Workers that was very detailed and helpful in outlining their recommendations for licensure. And I'm already hearing a good amount of overlap.
Okay.
So this document from the National Association of Social Workers, I think there's a couple of copies up front, and then we will be able to post your presentation and this letter after the media. I believe Camille is already posting her email if you have any questions about that, or posting the link. I have one or two questions, but if I may, let me see if my committee members have questions first. And you are number what, please?
23.
Thank you.
Yes, thank you. Yes, you need to shift. So a question in terms of, because one of the recommendation is to follow the the same pathway of defining the pathway for what we've seen for registered nurses and follow that as an example. So do we have any data in terms of how many nurses have been hired through that type of policy? How receptive the market is, like how effective that policy is practically.
I'm not currently aware of any data, but I can look into that and certainly get back to you. Okay.
I have a question regarding the credential evaluation services and who provides that?
I believe there's several companies that would provide something like that. Again, the rules and regulations are very reliant on some very specific accreditation agencies that, again, have very limited accreditation capabilities for foreign countries. So credit evaluation services essentially go beyond this. I do believe they're all private companies, but they have the knowledge and expertise to be able to accredit education and supervision beyond what the current established agencies can do. As far as the number, again, that's something I'd have to look into. But again, I do know other states are using these agencies and they are well established. So
Yeah, it seems to be a worthwhile solution
Sure.
for us. Would just question then, would the person seeking licensure be expected to pay for that?
right.
That's another, that would create another barrier.
Sure. Belisa would like to add something.
Sure, thank you.
Yes, there are agencies that are private. The process is very costly. We
Mhm.
just brought a professional with a master's degree from Colombia for an opening. It was non-clinical that we had. And the process of doing the visa and accrediting his studies in Colombia, so it was equivalent to Georgia because it was a requirement from the Department of Labor, was very costly, and the agency absorbed that. So that's why we recommended that we need to establish some sort of support for agencies to do this, because it can become thousands of dollars to do that.
Yes, thank you very much. And just one other comment. I understand that private providers do charge for supervision hours. I'd just like to make a comment that our state safety net providers, the community service boards, do not charge for those supervision hours. And so that would be a good referral for those that are needing those hours.
Thank you very much. If any of you have any experience or know any other entities, healthcare entities in Georgia that are using H-1B visa workforce people?
I'm not sure of that, but I did want to make a distinction between kind of what we are focusing on as opposed to H-1B visas. It's my understanding that you can be educated in the United States and be on an H-1B visa. And we were more looking at how to remove barriers for those who actually receive their education and supervision in foreign countries. But as far as any other agencies they're working for, I'm not aware.
Am I correct that we're going to hear later this morning from the Secretary of State licensing boards, but am I correct that the individual professional entities are creating the specific rules about supervision hours and process and not the Georgia General Assembly statute? Am I correct about that?
Do you want to speak to that?
As far as I understand, yes, there are different requirements that are created by the licensing agencies themselves.
Different kind of hours of supervision, different kind of
Correct.
timelines, whether or not you can take the test while you're still a student, all of those things. So that sort of generates for me, another opportunity that we'll hear more about. If y'all could talk to each other a little bit about whether or not there's anything in the statutes that needs to be changed, or whether or not just the individual professionals operating independently want to work together a little bit more about recommending something that might be more efficient.
It is very complicated. We have brought several, professionals from Puerto Rico. And even from Puerto Rico, being a U.S. territory, it is very complicated to navigate the system here.
Complicated and expensive. And is there a way for us to be helpful in a way to make it a little bit less complicated and perhaps share the cost in this crisis area that we are about staffing? Is there any questions on the chat or from the Zoom participants that we'd like to call on at this point? Okay. Is there anything else y'all would like to add? I see a little gathering over there about,
Yes, we did want to clarify that some of the rules and regulations for licensing are statutory.
Yes.
And then some of it is left at the discretion of the board. And I will say there is a lot of somewhat ambiguity and vagueness in some of the board rules and regulations, particularly with language such as, at the board's discretion or, board approved, not approved. So making that language a little bit more clear, I think would go a long way in helping people navigate the licensure process.
and then there's the entities of independent, like lawyers are
Mhm.
licensed based on the state bar supervised by the Supreme Court and not by the Secretary of State.
Right.
So the opportunity to have some discussion about what can the General Assembly do versus what encouragement the professional organizations can do themselves. So is a conversation that we need to have. Anything further from subcommittee members? Thank you, ladies, very much. Very appreciative.
Thank you so much
And
for
your
your time.
materials and this letter from the National Association of Circlers will be posted after the committee meeting. I'm going to move now to issues on our agenda: certification, credentialing, and licensure for behavioral health providers. And we're going to begin with a little bit of a discussion update on co-responder issues that I want to have hopefully some helpful clarification of what we're seeking. Call on at this time Carol Caraballo, who is with the Department of Behavioral Health, Developmentally Disabled. I believe she's in charge of all adult mental health services, and Judge David Sweat, who's been extremely helpful on the creation of co-responder programs and the statute that we passed, Senate Bill 403. Are both of them available at this time? And
Yes.
how do we
Yes.
make
Mhm.
them?
All right, Carol.
Yeah, will do. So good morning. Thank you so much for having us. If I may, I wanted to take a moment and kind of share a personal story. I really do appreciate the previous presentation on some licensure struggles. And I can say, though I'm not foreign trained, my licensure is from the state of Florida. And I was recently sharing this with Judge Sweat. Last month, I learned that I, at the moment, cannot be licensed in the state of Georgia because some of the differences in the requirements as it relates to the hours of clinical internship and the hours of supervision. So I very much relate to the discussion as I am currently facing that struggle. So I wanted to share that with you. So thank you for the opportunity to present today. Again, I'm Carol Caraballo, and I'm the Director for the Office of Adult Mental Health Services at DBHTD. Patrick, next slide. Thank you. A corresponder team is an approach that pairs law enforcement with behavioral health professionals to respond to a behavioral health crisis. The goal is to de-escalate a crisis situation, divert individuals to the most appropriate level of care instead of jail, and to increase access to behavioral health treatment and help promote engagement. Next slide. The target population are individuals that are utilizing the 911 system due to a behavioral health crisis that benefit from being diverted to behavioral health services instead of being detained in jail. Next. This slide shows some of the currently funded corresponder programs within the state. I want to point out that this isn't all of the corresponder programs in the state. There are other programs between the CSPs and law enforcement that are not DBHTD funded, and that list might be attained from the CSP Association. These are the programs that have received federal funds through DBHTD. 5 of these programs, if you note the ones that have an asterisk on them, those are currently operational, while the other 3 have experienced difficulties with hiring the licensed clinician. The COWIDA CARES program is different from the traditional corresponder model, as that program pairs a clinician with EMS, and that's also proven to be a successful model. The criteria that was utilized to select these teams was based on the areas that had a high number of behavioral health calls to 911, areas of high officer-involved shootings, and those densely populated areas. Next slide. HB 1013 and SB 403 brought forth some implications, as HB 1013 requires funding for 5 new corresponder programs. DBHDD received an appropriation for 10 additional sites. SB 403 requires that each CSB establish a corresponder program to offer assistance or consultation to law enforcement when they are responding to behavioral health crisis calls. Next slide. These are some additional 403 implications. We need to develop a state model for corresponders with the criteria stated in Senate Bill 403. There are some deadlines set forth in the bill by July of next year, and annually after that, DBHDD will submit to the board proposed budgets for corresponder programs for each CSB. Prior to July of next year, policies and procedures need to be completed. And by January of 2024 and annually thereafter, DBHDD will issue a written report regarding the corresponder program that includes statistics, CSB documentation, and reports. And this really is going to highlight the importance of data collection. Next slide. Prior to 403, DBHDD began funding the corresponder teams within our providers. We are currently working with these teams to assist in their implementation. And as mentioned earlier, there's 5 of those teams currently. These teams are required to submit monthly reports on data that includes demographics, number of calls, number of linkages to services, number of jail diversions, arrests, transports, etc. And we're currently working on additional data elements. We are in the process of completing a funding opportunity for the 10 new correspondent programs, and that should hopefully be released within the next month. We've met with the CSB Association Corresponder Focus Group to align our efforts as we move forward, and we've started our Corresponder Advisory Committee with the first meeting occurring in September, and our second was just right before this meeting. Next. The part of the work of the advisory committee will be the identification of training for CSBs, law enforcement, and 911 communications, and creating some consistency within those trainings. We also need to work on the development of a referral system that law enforcement may use to request a behavioral health consultation, work on the development of a transfer from one CSB to another, the standardization of data collection. That's also going to help with addressing some of the gaps across the regions and hopefully help us to continue to refine policy and protocols for the teams. As we know, corresponder programs aren't a one-size-fits-all approach, especially when we compare the differences in our counties across the state. Next. So as I mentioned earlier, our advisory group had its first meeting last month and again this morning. Some of the focus areas that have initially been identified include diverting individuals from the criminal justice system, data collection, our workforce discussions, and development of protocols. The makeup of our advisory committee consists of representatives from DBHDD, both the state and regional offices. We have 1 CSB from each of the 6 regions, Mobile Crisis Response Team, the CSB Association, Georgia Mental Health Consumer Network, law enforcement representative, and the court, specifically Judge Sweat, who sits on our advisory board. Next. So as we move forward, we have some opportunities as we work on refining our corresponder programs by continuing to work with our advisory committee and with other stakeholders. We have the opportunity to continue to build rapport with our law enforcement partners, an opportunity to review the various existing policies and procedures from working with our partners. We look forward to being able to standardize some of our data across the state. And we have a great opportunity to increase public knowledge of corresponder teams and how they help manage the mental health crisis by linking individuals to appropriate care and reducing incarceration. Some of the challenges include the workforce shortages as licensed clinicians are in high demand, as we've been listening to across our system, and the increased risk of this type of working environment where a clinician may be in a police vehicle all day. As I mentioned earlier, 3 of our funded teams are having those difficulties in hiring a clinician. We also need additional funding to assist with the various trainings that will be needed for this work. And we need to identify other funding opportunities to sustain these programs moving forward. Next. So that was a very quick overview of where we are with our corresponder implementation. And at this point, I'll turn it over to Judge Sweat.
Thank you, Carol. Thank you for that great review. The good news, as I have heard just even recently this morning from the director of one of our community service boards, is everyone is wanting co-responders. That meaning particularly our law enforcement agencies are very interested in entering that partnership. Before I talk more about it, I want to just remind us that you overuse the term co-responder program as an overarching term, but there are really several different parts of it. One is the what we think of as the crisis co-responder, those individuals that might go to a scene where there's an individual in a behavioral health crisis, either accompanying law enforcement or being dispatched to meet law enforcement to address a crisis situation that is taking place. But our co-responder program from our community service boards will also have some other important elements. One is the community follow-up, because we know that community follow-up and outreach to individuals who have experienced a behavioral health crisis, and the law requires the community service boards to do that, to reach out to try and connect people to services. And we think that's the way we can intervene and change the scenario with individuals who are having a behavioral health crisis. So that's that community follow-up piece is very important. And the other big piece is what we've called jail outreach, but really is more jail monitoring. And it's a process by which we can identify individuals who may be in custody in our county jails who might be more appropriately served have their treatment needs served in a community setting. And so that's another piece. And that may be more like a case manager type person than if you look at the licensure, whoever might be doing it, we've got available the licensed individuals, we've got certified peer specialists, and then others who are working with our community service boards. So they're big pieces. Those are the big pieces of it. I think our focus, and a lot of focus is rightly so, been on development of emergency response, because that's where we see so much poor outcomes and where we see a real opportunity to divert people at a time when they can be addressed and we can keep them away from our jails. There are 22 community service boards in the state of Georgia. 12 of them have already developed or in the active process of developing co-responder teams. And when I say a team, I mean that group that may go out in response to an individual in behavioral health crisis. There are active in the community service board, amongst them, the community service board's 20 active partnerships with law enforcement for crisis co-response. And we've had a lot of contact with our law enforcement agencies contacting us, or we've had 53 contacts we've made to law enforcement agencies. We've had over 20 law enforcement agencies contacting us. We see that number increasing, particularly since we have just begun the dialogue between the community service boards and our police chief association and our sheriff's association. And we've got plans for presentations with those groups coming up in the next few months. And we think we'll see more engagement. One of the pieces in how we build that is that each community service board is tasked to set up a co-responder protocol committee and each law enforcement agency that responds to emergencies in that community service board service area is obligated to appoint a representative to that committee. And we believe that that's going to be where we start working out how we can scale up our services, but also work out with our law enforcement partners, how we can best serve the communities that they serve. We hope that that's going to lead to more collaboration between not just our law enforcement and community service boards, but also our emergency departments and our EMS services, the other folks who are engaged in crisis response to individuals in a mental health or behavioral health crisis. So, the challenge is going to be scaling our co-response to a statewide level. We've got a lot of work to do, and our community service boards across the state are working on that actively and how we do this, and we're working on protocols. We're also talking about training, because the way that the 403 is written, the certification for why can't I find that now? It basically an individual can be part of a community service board co-responder team if they are either certified or licensed and are providing services and supports through the community service board. So 403 does not define exactly who the licensed or certified person has to be, but it's by reference to their functions within in their licensure and certifications that they can perform these services with our community service boards. And we've had a lot of discussion about who are the individuals who are going to be filling the role of the co-responders. And we know that we have a shortage of licensed individuals. Athens-Clarke County, for instance, has had 3 teams a few months ago, and we've lost 2 of our co-responders. We're down to 1, and we have been recruiting constantly. One of the things that I frequently hear is that we are not necessarily offering clinicians the salary that they would like in order to get in a car and go and engage in a crisis response.
Judge Sweat, I'm going to interrupt you for a second, because you're hitting on something that I want to go down a little bit deeper. You and I and Monica Johnson have had a discussion about what exactly is the license that is required under the language of 403, and she has been helpful, I think, in granting some waivers of that. Can you talk about that? And specifically, what I want to know from your perspective is whether or not we need to make a small amendment or tweak to 403 language about license.
Well, and I think there is a waiver for some individuals to function kind of as licensed, and Carol may be better able to answer the question, but individuals who may have obtained a degree, but yet haven't obtained any other kind of licensure. And that would apply to a lot of people. And as our community service boards do have the opportunity to train a lot of individuals because they're in clinical social work, because they need so many hours of proctorship in order to reach their licensure. But I'm not sure that I would suggest changing 403, because at this time it's sort of more open-ended. And if we start defining it and limiting it, then it may limit the co-responders or the individuals who can serve. I think one way we can address it, though, is to start creating a co-responder training program, so that, because co-responders have got to become familiar with police practice and other things outside of behavioral health. So, and there is, the code was changed so that you can do co-responder training at the Georgia State Training Facility. But I think the community service boards and in discussion with Carol have been, what do we do to set up sort of a program so we can get to a point of having co-responders train whatever their licensure may be. And it's always more desirable to have a clinician, but when we just don't have enough, and we don't have enough certified peer specialists either. We're all over. That is a shortage of those individuals. So we're trying to figure out how to meet this needs. And there may be others who have the background that can engage in the co-response, either retired police officers or other people that have kind of experience that would lend itself to being an effective co-responder. So I think the way forward is, we have a heavy lift with all of this, has been doing all these things, but the way forward may be to look at certifying persons as co-responders for the individuals who may be responding to behavioral health crisis, not those who may be doing community follow-up or working on our jail monitoring piece.
Representative Jasmine Neal's part of the bill was to create that co-responder program at Post, and we are doing a lot of heavy lifting here, and the successful rollout of co-responders is really important. I'm going to ask Cindy Levy at this time to participate, because she's been participating in co-responder staffing for a couple of years now, and thank you.
Sure. Thank you very much for the opportunity. And I've worked very closely with Judge Sweat with Senate Bill 403 and everything that's happened since then, since its passing. So as far as the experience, our Community Service Board, AVITA, has been working with Forsyth County Sheriff's Office to implement a co-responder program that has been in existence for 2 years now. And we do have a licensed professional counselor who is part of the team. And then we also have a certified peer specialist. So as we've heard, there are different components to the co-responder team. And one of them is to have a clinician to go out and respond to calls with law enforcement. And so having a licensed clinician, the difference, a fully licensed clinician then also has the ability to initiate the 1013 involuntary commitment process if necessary. And so that's one of the things that is in question with regard to an associate licensed counselor does not have that capacity. And so when we look at the shortage of licensed clinicians that are available, we can look at the possibility of utilizing an associate licensed person with perhaps a licensed person on call or some other means to that end of the initiating the involuntary commitment process when necessary. And I'd like to emphasize that that's not always necessary. Last year, our co-responder team responded to 381 calls, only resulting in 3 arrests. And there were only about a dozen that required the initiation of 1013. So a lot of it is just having that person that is trained in de-escalation, trained in how to approach an individual that does have a mental illness, understanding the symptomatology that they may be expressing at that time. And so all of that needs to be taken into consideration. When we look at the follow-up, because that's a very important piece of it, and that's where the certified peer specialist comes into play. As Judge Sweat referenced, going into the jails and interacting with folks that are in jail and are incarcerated that perhaps would be better served with treatment than actually being incarcerated. Josh, our certified peer specialist, is regularly in the jail and interacting with individuals that have been incarcerated and then working on their release plans. Also, once there's an encounter with the co-responder team, so the law enforcement and the clinician, there has to be follow-up after that. So there is that one encounter, and if they were not taken to jail or they were not 1013'd and taken immediately for a mental health evaluation, well, then what? What happens as far as the follow-up? So that's where the certified peer specialist really comes into play, where they're able to do the follow-up phone calls, the follow-up meetings with them, also helping to link them to additional services and supports that they may need in the community so they don't have another altercation with law enforcement. Is that helpful?
It's very helpful. And I just want to be mindful that questions are coming up. One question I have, and Carol, you may be able to, is the CSBs where you are having the greatest staffing needs, are they geographically where? All over or rural areas or what?
I think the ones that we're having the staffing issues that I'm aware of are in the rural counties. I do want to say that, we've had some of the discussions as far as the clinician piece and looking at the associate license, like Cindy was mentioning, and those very, kind of like a tier system. Obviously, a licensed clinician is probably the best option in case there is that we need to do a 1013, but an associate licensed clinician should have those skills that are needed to be an effective co-responder. So we are looking at that because we don't want to hold up the process of developing this teams moving forward. So we are internally having those discussions as far as what licensure and certification.
And when you say you're having those discussions, what I understand is that you do not think you need an amendment to the statute to allow an associate to have a role in a co-responder team.
So I don't know that I can say that we've made a determination that, but I'm in line with Judge Sweat. He is part of our advisory committee, and those discussions have been happening and will continue to happen in that format.
Thank you very much. Is there anybody else has a question? And I'm going to allow a person from the audience to ask a question because he's a special person.
Well, I'm short, at least, you know. Just listening to this
Tell us your
conversation.
name, please.
Oh, I'm sorry. My name is Stan Jones. I'm a lawyer lobbyist with Nelson Mullins Law Firm, heavily involved in mental health, both for clients and as a volunteer. And in just listening to the discussion, I'm keenly aware that the Mental Behavioral Health Commission was very proud of lifting this up. And so now DBHE has come forward and described, I think it was 12 CSBs that are actively involved, which Cindy's just described, and another 20 that are becoming involved. So to me, it led to the question, is the issue scaling up? I mean, you know, one correspondent and one peer specialist at Avita is probably not enough to cover the 12 or so counties that Avita covers. And I do think as we're heading into other iterations of the commission, we kind of got to get to the scale issue because that leads to the money issues. And so there's both a capability, a motivation, and a scale geographically and volume. So I'd like to get that sorted out as we move toward this session. I know we can't do it right now, but at least that's something that occurred to me as I was listening.
I think we are on a very fast growth pace with a lot of demands, and that we are interested in this program being very successful. So the associate degree status seems like a solution, at least for the immediate future. So I look forward to y'all's report on that. Is there any other questions from the Zoom crowd or any of my committee members? This is very helpful to me.
I believe what you were referencing, Representative, is the associate licensed. So it is an individual with a master's degree, and the legislation as it stands currently does reference licensed, and that is an associate licensed. So that does allow for that individual to be a co-responder, which does allow the flexibility. And I believe that's what Carol was referencing.
Thank you. I think I understand it now. And the extent that Justice Boggs was interested in this question, we'll be able to talk more knowledgeably with him. Thank you, ladies and gentlemen. I appreciate it very much. We will move on at this time to Leslie Austin, who is with the Department of Community Health. We'll talk about that agency's issues in relation to licensure. Is she available by Zoom, I think, or is she with us this morning? Wonderful. Wonderful. Please introduce yourself. Thank you.
Good morning. I'm
Morning.
Leslie Austin. I'm the Provider Enrollment Manager with the Medical Assistance Plans with the Department of Community Health, Georgia Medicaid. Nice to be here.
Thank you.
Next slide. Next slide. Next slide. All right, who can enroll as a behavioral health provider in Georgia Medicaid? Physicians, psychiatrists, board certified behavioral analysts, master's level BCBAs, and BCBADs with doctorates for autism services, psychologists, marriage and family therapists, licensed professional counselors, psychiatric nurse practitioners, and licensed clinical social workers. Next slide. Licensing is a process for professionals to be deemed eligible to practice in his or her field in Georgia. And credentialing is a separate process to deem that particular provider to be an eligible Medicaid provider to render services to our Medicaid members. Next slide. Licensure is a process by the independent licensing body for each provider type. Physicians, Georgia Composite Medical Board, psychologists, State Board of Examiners for psychologists, marriage and family therapists, licensed professional counselors, and licensed clinical social workers are all licensed through the Board of Professional Counselors, social workers, and marriage and family therapists. Next slide. Some provider types are certified rather than licensed or have a certification. And that would be your BCBAs, BCBADs, And they have a certification in behavioral analysis certification through the particular board. And psychiatric nurse practitioners have to have both a nursing license through the nursing board, as well as a certification through ANCC, which is the American Nurses Credentialing Center. Next slide. Credentialing is a formal review of qualifications and other relevant information, including background and assessments for a provider who has applied to the Georgia Medicaid program. For them to be contracted with the CMOs, they have to go through credentialing, and that's every provider if they wish to render services to a CMO member or a fee for service. Every practitioner in Georgia Medicaid must be credentialed. And Versius is NCQA certified, which is National Committee for Quality Assurance, and they do our credentialing for us. Next slide. The credentialing standards apply to the following practitioners: all licensed practitioners, groups of practitioners who provide care to Georgia Medicaid members, non-physician practitioners, facilities. It is a streamlined process, which is single point of entry, and all of our credentialing process is done online through our MMIS system, web portal. Everything is electronic. There is one credentialing committee, and the CMOs receive the re-credentialing package, which contains all of the credentialing information, documents, as well as the credentialing decision. The providers are notified of the credentialing status if they're approved through the MMIS system or by certified mail if they're denied. Now with COVID, we send that particular letter via email to them. Next slide. Some of the credentialing activities include confirming and verifying the curriculum vitae, which is their resume, verifying the licenses and certifications, verifying if the practitioner has the active drug enforcement agency or DEA certification, protocol agreement if they're a nurse practitioner to dispense drugs, or control dangerous substance, the CDS certification. We verify the provider's education has to be 3 or more years to render those services to Medicaid members, as well as their work history. If there are any gaps, 6 months or more, they have to explain why in a detailed explanation, either on the application or in a separate form. We verify malpractice insurance and any claims history. Verify social security numbers via the SSA Death Master File. We verify hospital milling privileges, or if they have an admit plan, someone who can admit on their behalf. Medicare, if they wish to see Medicare members, if they're Medicare enrolled. We conduct fraud and waste abuse sanctions for the provider, credentialing committee review, and any requirements, ACA or NCQA. Next slide. The credentialing committee consists of 8 members. They are not appointed, and they consist of 4 members from the CMOs, which they're board of directors or actual directors. And then the other 4 are employees of Versius, but they have to be enrolled as Georgia Medicaid providers as well. And some of those providers on the board have different various specialties. We have an internal medicine provider, psychiatrist, OBGYN, dentist, infectious disease, and pediatrician. We also have peer review specialists if we need outside consultants like an optometrist or insurance coordinator. Next slide. Also, the committee meets weekly, but no less than once a month. Can you go back, please? Thank you. The credentialing and contracting are separate with the CMOs. Successful credentialing does not guarantee a provider can be contracted with the CMO. Upon receipt of the credentialing decision, the CMOs are expected to expedite that contracting process, and the CMOs may not use the contracting process to circumvent the credentialing process. Next slide. If you have any questions, please contact Brandy Sylvan, our Director of Government Relations at DCH.
How much consistency is there among your CMOs on their individual, perhaps different credentialing decisions?
Everything goes through Versius and DCH. They have to accept the actual decision that was made, either denied or approved. But they don't do any of the credentialing process.
So a provider with one CMOs will have the same opportunity with other CMOs
Yes, ma'am.
to be employed.
If they wish to contract with them, that's their decision.
Any committee members have questions about that process? Does anyone?
Well, it seems that the process is quite involved. When organizations apply for the credential, I guess they have a system that they can work with, and do individual providers also apply, and how that would work for individual providers?
We only enroll individual practitioners.
Okay,
As far as the groups, those are hospitals, hospice facilities. But each practitioner must enroll. The actual group or business is their taking on record, meaning who the funds will be paid to. But each person has to submit an application.
so if a practitioner works with a group,
Mhm.
it has to first be applying for credential, and then will be able to work with Medicaid patients.
Correct. So they have to be
Medicaid.
credentialed first. Yes, ma'am. They have to be enrolled, have an active provider ID number.
All right, so that the application goes, the group would apply for the practitioner, or the practitioner will apply?
Whomever,
individual?
however they run their business, they can do it themselves. Or usually it's someone within that practice, like an office manager or a staff member who submits an application on their behalf.
Yeah, thank you.
Thank you very much. I'm happy for you to come question. You have to come to the microphone so the folks in the Zoom world can see you. And please identify yourself.
Hi, I'm Gail Mackey. I'm the Executive Director of the Licensed Professional Counselors Association. And I'm so excited to see you here. Our organization has just a couple of questions, and please correct me if we have any of this information out of date or incorrect. We learned that in January of this year, LPCs were included. We're just so excited about that. We read the documentation, and it appears that LPCs are approved to provide Medicaid services from age 0 to 6. And then it looked like it might have something up to age 21. So we weren't sure. It looked very clear in the documentation that they could provide the services from age 0 to 6, but it isn't quite as clear on from 6 to or 7 to age 20.
Who they can render services to?
Yes.
I'll have to get that information for you
Okay.
via policy.
Okay, great. 'Cause we're just so excited about that. And I know, of course, as our population ages, we're not able to provide the services because in the older population, it is tied to Medicare, which we are, of course, actively working on that too. So we're very excited. I know our membership, we have about 8,000 are very excited about being able to provide additional services.
Are they all enrolled?
No, but we're going to work on
Work
that.
on-
real
okay.
quick. So thank y'all.
Thank
very
you.
much.
That was a
Appreciate it.
change by the General Assembly, or was that a change by DCA?
It was through a SPA amendment. We're
What
now
amendment? A
LPCs.
What amendment?
SPA, state amendment, a state plan amendment.
Okay, so it didn't have to be a statutory amendment. You, the DCH, were able to expand that opportunity for
Yes,
other
ma'am.
professionals without any legislative need.
I think so. Yes, ma'am.
Okay. thank you.
And that means it was opened up to marriage family therapists as well as licensed professional counselors under category service 570, which we renamed.
And I
Psychology,
appreciate
behavioral
you
health.
asking that question because I've been asking it on behalf of the family therapists too. So we'll
Mhm.
get some clarification on that. Thank
Yes,
you.
ma'am.
Any other questions or comments for Ms. Austin? Thank you, Ms. Austin, very much.
Thank you for this
Appreciate it for
opportunity.
coming.
Thank you.
We now will move to Secretary of State, Brig Zimmerman, who is the Executive Director, Georgia Composite Board of Professional Counselors, Social Workers, Marriage and Family Therapist, and he is participating with us by Zoom.
Good morning.
From Macon today. Good morning. Thank you
Good
for being
morning.
with us.
I'm glad to be here. I wish I'd had a little more time to prepare, seeing how I feel like I'm on the hot seat because I am the executive director for the Counselor Social Work Marriage and Family Therapist Board, but I'm also the executive director for the Board of Psychologists, as well as the new Behavioral Analyst Board that'll come online this year by July 1, 2023. So I've heard an awful lot about licensing this morning, so not sure what I can do to help right now, other than offer maybe whatever information I could. There seems to be a lot of talk and discussion around. Well, at first there was a good bit around foreign educated, and I will tell you, I've been the director of these boards for over 15 years, and I can probably count on maybe two hands the number of foreign educated folks we've had, maybe more than that. We haven't had a whole lot. And the credentialing process is difficult and it is expensive. I have a list of 15 or so providers throughout the United States, but that list was generated originally by the Georgia Board of Podiatry. So it's kind of hard to get through that process. So I'm hearing a lot about the licensure process, the delays, the encumbrances that people are running into to get licensed. And I hear you. Just one statistic that might help a little bit with regard to applications. I just looked quickly yesterday while I had a minute. In 2017, my staff of 5 and I processed 3,684 applications for the composite board, which were counselors, social workers, and marriage and family. Through this morning, we've already processed for this year 5,130. So over the last 3 or 4 years, the applications have continued to increase, just hundreds and hundreds a year. So we're working as fast as we can, and you'll hear Ms. Mackey speak in a little while. Mr. Livingston, I'm very familiar with. He used to be on the composite board as well as a marriage and family therapist. Is the staff does a good job in processing, but we do have a lot, and so any help we can get is appreciated. The statute was changed this last legislative session that will help going forward. Representative Oliver, back to a minute ago, you mentioned the rules and the laws. The law gives the board the authority to generate or to state how many hours somebody needs of directed work experience and supervision. So the board does have a little stricter than some of the other states with social work and with counselors. But some of the changes that were made in this past legislative session are going to help going forward because they've reduced the number of years of directed work experience for counselors from 3 to 2. And also the education level has changed a bit. It requires a 60-hour semester, 80-hour quarter for a master's degree to be accepted. So right now we're struggling with all that. That became effective July 1st. So again, I don't know what I can offer you this morning. I hear your concerns about licensure, and I'm in agreement with a lot of them. As with everything, more staff, more money always helps.
Your applications, it sounds like have grown from 3,000 to 5,000. That's rough. Since 17. I can't do the math quite fast enough, but that's a 70% increase, 80% increase. Has your staff increased from 5 people since 2017?
No, ma'am. Until recently, September 1st, I was able to add one more, what's called a licensure analyst, which is the person that processes the applications. So we're in the middle of training her and getting up and running. That's going to be a tremendous help. Given all I've got, I feel like I could use a couple more, but we're working on that. I have a lot of people that are very helpful and are really trying their best to get me what I feel like I need for adequate staff. And I'm not making excuses. I'm
not asking. I don't. We all sit on various hot seats around here.
Yeah, I just feel like I'm on one this morning.
you're on the one that a lot of people are looking at,
right.
And I just want to be helpful because
Absolutely.
It seems to me that if we've got a 10% increase of population and a 70% increase of applications, and our timelines are painful, and we have a crisis of workforce, that you need more help.
Yes, ma'am.
And I certainly am sympathetic. Hypothetically, if the Secretary of State came forward and said she would like more people to help, I'm certainly sympathetic to that. I'm also very interested in, and I'm not qualified to lead this discussion or even participate in it, but I really want to have an understanding of why Georgia's your board's credentialing seems to be more restrictive than most other states. And the supervision hours, we're making some changes there, but I'm just really want somebody to, with some real depth of knowledge, to explain to me, is Georgia an outlier? Are we too restrictive? And can that question be answered differently from people coming from other states or other countries? That's a real serious inquiry, but I'm immediately sympathetic to the fact that you need more help.
Right. And we have increased. Psychologists have stayed about the same. I'm expecting 12 to 1,400 behavioral analyst applicants the first year. That my understanding, that is roughly the population. I also am the director for the Speech Language Pathology Board, but I don't think they have touched on that board. I didn't see it in the legislation, but it's there are some statutory concerns that people are working on to try to get changed. For
Who's
instance,
working on what?
The association, National Association, Ms. Mackey can talk a little bit more, as well as working with the Georgia Association of Social Workers. They're trying to get our Practice Act in a little more in line with every other state. As you said, we are have a little bit more stringent requirements than other states. That they're trying. One of the things that prohibits, I guess, the movement quickly of an application is I have 3 members of each profession sitting on this licensure board and 1 consumer member. So those 3 members of each of those professions are required by law to review and sign off on every application I receive. 2 of the 3 have to agree, whether it's denied or whether it's approved or whether it's pending or whatever. And that can slow things down a little bit, as you can imagine. We right now, and I'd encourage you to look at the minutes of the board meetings from the past couple of 3, well, really going back several years, and you'll see the number of applications going to the board are from 250 to even up to 400 each
And that's a
month.
volunteer position, isn't it, for the board members?
They are appointed by the governor. Yes, ma'am.
Volunteer position.
Mhm.
And how many additional hours are required for that volunteer position based on actual paper review or digital review? How much is original signatures required? All of that is something I'm not asking you to answer right now. I just
Right.
think that we've really got to look at this process to shorten the amount of time and shorten the bureaucracy. I think that's a big need from the professions and a big need from the public. So we'll be working with you in the next
Great.
month or 2.
Great. Because like I say, the staff I have are the best in the world. I've had them, many of them have been, one of them's been with me over 15 years. They do a great job, but I think we could do a better job, and we could probably process a little quicker were some of the administrative constraints taken off of us as far as thing. Now, the counselors are real, they always, as far as that statutory, I don't know where it came from, when it was put in place. I assume it was from the get-go. And it has made it a little hard because right now they're all full-time employed. They have their private practices or in the hospitals or wherever they're working. And we're asking them right now, I have a meeting 2 days a month, the full board one day and a committee meeting the other day. And between complaints and applications, you're talking about, I'd say, a good 10 to 12 hours a week for each board member to have to put into this. And they do an awful lot without really any sort of pay or anything, which is not the driving force. They all tell me they're on the board because they're proud to be a licensee and proud to serve
Yeah.
on the board.
They're doing it without staff support too. I mean, they're doing it on their own.
Right. And I've been lucky. Staff have been good, and I've been able to fill positions as I've needed them. I just would like I said, I need a few more, but that you'll hear that from each one of the executive directors at the licensing board. That's just but we're going to do the job, and I'm looking forward to seeing how this moves forward. And I'd love to help some of the speakers that did earlier as far as application problems that they run into. I'm easy to find. Each board has a link to my email address, and would love to see if I can help any of them in any way. I don't want to turn people down.
Committee member have questions or suggestions or comments? Thank you, Mr. Zimmerman. I really appreciate
Yes, ma'am.
it. Thank you very much. And we will now move to recommendations and testimony from individual license holder groups. And we'll start with the Georgia Psychological Association. And we have with us this morning, if you identify yourself, please.
The Director of Professional Affairs for the Georgia Psychological Association. I also have my doctorate in psychology.
Thank you for being with us this morning.
Thank you. We have another presenter who's online and she will follow me very briefly.
Thank you. That's Dr. Shannon Mullins. Will
Correct.
follow you. Thank you.
So next slide, please. The Georgia Psychological Association, we have approximately 900 members. We are associated with the American Psychological Association, not a chapter, but independent. We are the representative for issues related to the practice of psychology in Georgia. Next slide, please. In terms of our presentation objectives, we'd like to detail the psychology workforce, what we do, where we do it, challenges, and also have some pretty specific remedies and/or information that we need to assist in improving access to care. Next slide, please. The profession itself is quite diverse, and we practice and teach and do many other things across multiple settings. The kind of psychologist that you're probably interested in today is the clinical counseling, or more generally, the applied subfields. But you should know that psychology is a vast field, and there are many psychologists who probably wouldn't know what to do with the mental health disability or problem if it was sitting right next to them. So psychology is broad and diverse, but we're talking about the applied fields today. And we engage in the list of topics and or practices and procedures that you see listed, ranging from treatment, of course, counseling, consultation, teaching, training, and administration. You can find us in many, many different settings of healthcare delivery and also in private practice. Next slide, please. The entry level for the psychology profession is a PhD or PsyD plus postdoctoral training. It consists of a common core of coursework, practicum, including internship and postdoc, specialization in either clinical child school, neuropsychology, forensic, or health psychology. Those are the applied fields. It requires a research-based thesis and dissertation and comprehensive examination, oral and written, to complete the degree. Next slide, please. Beyond the degree, well, just so you know what happens with training in Georgia, there are 5 doctoral institutions, 9 programs. You can see them listed there. Emory, Georgia State, UGA, Mercer, and Georgia Southern offer degrees in clinical, counseling, school, and industrial organizational. Our adjacent states, North Carolina has 9 programs, Florida 17, Alabama 5, and South Carolina 2. There are 11 internship programs, usually most of them in university counseling centers, healthcare settings, and the VA, and the comparable statistics for adjacent states to us are there. Next slide, please. The key point to that is that people stay and practice where they went to school and where they did their training. So, or in that general environment. Once you've spent the 5 to 7 years that are required for the doctoral degree in psychology and the postdoc, you probably are pretty stuck where you are. The American Psychological Association accredited postdoctoral programs in Georgia are counseling centers, VA, and healthcare. All located in the Georgia metro area, with the exception of the Georgia Southern PsyD program and the Augusta internship. So once again, we begin to see this rural versus urban divide, both in training and in the placement of practitioners. The Georgia rules do not require an APA accredited postdoctoral training for licensure, but there are relatively few postdoctoral training programs. Private practices and other organizations can offer postdoctoral training, and so that's good. but it is required for licensure, next slide, please, to have an APA accredited doctoral degree. This includes, as we said, 12-month approved APA internship and typically 5 to 7 years of graduate training after the undergraduate degree. The postdoctoral experience is 1,500 hours of supervised postdoctoral training. Examinations for licensure require a 2-part national exam. It's called the EPPP, parts 1 and 2, a state jurisprudence exam, and a state oral exam for licensure. Next slide, please. Catch up with my notes here. I would like to speak to the degrees that are obtained internationally, just to sort of segue from other speakers this morning. Typically, the entry level for psychology in other countries is the master's degree. So you have that sort of a hurdle right there. The doctoral degree in psychology in other countries is typically mostly research and academic and teaching. So to come into the field in the United States as a fully functioning provider of psychology services, you probably would have to go back to school and get the doctoral degree. There's a great interest at the national level in trying to find some way to bridge that gap, usually with programs that will accept people with master's degree that were obtained from foreign institutions. So that's probably the biggest hurdle for the profession of psychology, is the difference in the entry-level degree for practice in the profession. In terms of licensure, the bottom line up front for us is that we really don't have a significant problem with licensure as a barrier to practitioners in Georgia. It happens further downstream for the profession of psychology. And it's at the lower level of our concerns. Credentialing is probably a bigger issue than licensure. And by that, I mean credentialing for instance, becoming a DCH Medicaid provider. So we'll talk about that in just a minute. The Georgia licensure requirements are listed there. Can we move to the next slide, please? We have 2,519 licensed psychologists in Georgia. The licensure process is eased for Georgia psychologists by the ability to bank your credentials with ASPPB, which is the Association of State and Provincial Psychology Boards, international association and headquartered here in Tyrone, Georgia. So we're close to home. It allows for easily accessible database or data banking of your information so that if you go to another state, that state can access your banked credentials once you've done that and easily provide the information needed for licensure across states. This data banking is utilized by the Psychologist Board of Examiners in Georgia and in other states. And the biggest issue is getting the providers to bank their credentials and to bank them adequately and appropriately. So it's not, the biggest issue is not having your credentials banked with the ASPPB. There is also, with the Georgia Board of Examiners, an expedited process in place for military-related personnel so that they don't necessarily get moved to the head of the list, but we do want to make sure that military personnel are being licensed in Georgia expeditiously. Brig, most graciously, he said very gently, he covers 7 boards plus the pending ABA board. And so that in and of itself, that staffing issue for processing the credentials for licensure is a big issue with the low workload that he and his staff endure. Next slide, please. One of the challenges to our data collection well, go back a slide, please. I think I've missed one slide. Could you go back a slide? Okay, next slide. I'm sorry. And go to the next slide. One of the issues for us with data collection is that as an organization, we cover less than half of the number of licensed psychologists in Georgia, and we can only get the data from our members. There was a time, I think, when licensure data was shared pretty openly, but at this point, and I think this is by statute, the board was forced to stop sharing information about psychologists who are licensed. So we don't have a lot of information to give you other than for our 900 members. And we know that they're mostly urban, a good degree of ethnicity, diversity, and gender diversity. But in terms of knowing what exactly our psychologists are doing in their practices and where they're working would be very limited were we able to provide that information. One of the solutions to licensure is that we are part of an interstate compact, have been since 2019. It's called SIPACT. The current number of enrollees total for SIPACT, which allows for interstate telehealth and interstate temporary practice of psychology. There are 6,472 psychologists enrolled in SIPACT across 33 states, so that those psychologists can practice into Georgia using telehealth, and the 333 current Georgia enrollees can also practice out of state. It contributes to linguistic diversity. Many times a psychologist who's in SIPACT, who speaks a language that is needed in treatment, can do that across state lines using telehealth. And the other thing that makes the psychology services more portable under SIPACT is the diversity in the services, the specialty services that psychologists provide. So those are two pluses for us having been enrolled and involved in SIPACT and part of that compact. Next slide. If we talk about solutions, it really is expanding the ability of psychologists who are licensed in Georgia to provide their services. One solution involves Medicare reimbursement for psychology interns and postdocs. We are not currently able to bill under Medicaid for these services. And many times these are the boots on the ground people who are doing the assessment for particularly children and youth. Georgia Medicaid rules only allow for reimbursement of psychological services provided by a licensed psychologist or their employee. And so one of the things that we would seek would be a change in the Medicaid payment manual so that these postdocs and doctoral level interns could be reimbursed for the services they provide under supervision. And we are in the process working with Nelson Mullins to do that. Next slide, please. This is just more information about why this cohort should be included in Medicaid reimbursement for their services. Next slide. Next slide. Okay. And so that is our goal. And I think I've said that in the interest of time. I will not detail it. Next slide, please.
Let me say something about
Yes.
reimbursement. 1013 offered up a direction to DCH to give us an analysis of reimbursement, and all of us in every way working with the commission is interested in that study, and that the payment schedules in Georgia just simply don't work, in my opinion, in a number of different ways. So I want everybody to know we're seriously looking for DCH for some guidance in the way we need to reimburse
So we
folks at
are
a better level.
looking for a regulation change that the next slide provides examples from other states that do reimburse at the doctoral or postdoctoral level for those services. Other issues for us, next slide, please. And I'd like to flip to my colleague, Dr. Mullen, who's in Thomasville, Georgia, are the models for service delivery would greatly enhance, I think, care. Most psychologists are private practitioners in our membership database at any rate. And so to be able to work in an integrated care model in institutional settings or in systems level settings. There are two models that one is called a coordinated care model or collaborative care model, which is headed by a psychiatrist, and other members on the mental health team operate under the guidance of that psychiatrist, but there are no psychiatrists to head these teams. So APA and at the national level has proposed what's called an integrated care model, which is, I think, much more robust and would utilize our services. The reimbursement hurdles are our main goal to overcome those. Relationships with insurance carriers unrelated to reimbursement. And I'm going to ask Dr. Mullen to sign in at this point to give you just a brief sense from someone who is an actual provider of sort of her history of this, just to introduce it. And I'm sure that more work will ensue. So Dr. Mullen, if you are around. and
Thank you, Dr.
available.
Mullen, for being with us. We appreciate it very much. We are seeing you on the screen, and if you could, if at all possible, focus on what it is you think that the licensure process of Georgia, the credentialing process of Georgia, what are the solutions to make that system work more efficiently is where we would like you to focus your discussion if possible.
Very good. I did submit some slides. I don't know if they're able to launch those as well. So as that's kind of happening, I'll start a little bit of an introduction. So I'm a licensed psychologist in Georgia, but I'm also licensed in Florida. Thomasville, Georgia is very near the border of both states. And so a good portion of my staff are dual licensed. They're licensed in Florida and Georgia. I'm also a PSYPAC clinician. I have a private practice that runs about 10 full-time multidisciplinary staff and also about 4 or 5 interns or part-time staff. I also supervise postdoctoral level clinicians. I do so free of any additional cost to them because, to be perfectly honest, it's very difficult for psychologists seeking a postdoc to find one and to find one on which they have appropriate compensation. And it's also very difficult for me in rural Georgia to recruit clinicians to my underserved area unless I provide that additional benefit. So if you would just advance the slide, thank you so much. So about 10 years ago, well, actually, no, 12 years ago, I was licensed in 2010 by the state of Georgia and opened my private practice. Even though I'm in Thomas County in Thomasville, Georgia, patients drive from Macon down, from the Alabama border down, over from Savannah. I'm that underserved of a community. And so you've heard a lot today. It's been fascinating for me to hear that there is definitely an experience of workforce limitation in the Atlanta metro area. Rural Georgia has some particular issues that are hopefully something I'd speak to today. Please advance the slide. One of the issues is, as difficult as it is, as high as those hurdles are to get licensed and get that out there to practice, get through that postdoctoral experience, is that we are losing clinicians out there in Georgia to serve our community. Part of the issue is what I call legal fiction, insurance companies creating false barriers to psychologists becoming impaneled. Advance the slide, please. Thank you. So let's say you do get licensed. You finally found a postdoc that wasn't, particularly predatory. And now you can't figure out a way to get paid. Insurance companies say, oh, our panel's full, but you look at the panel and half of those people aren't practicing. They're retired. I myself took the time to go through one insurance company's entire panel and call every single number on there to prove that the patients coming to me seeking service to be reimbursed with their insurance company had no other option. And that was a lot of work for me, the clinician. Losing applications, you apply to be a provider for these insurance companies. Oh, sorry, we lost it, reapply. Or you know what, we're closed, check back in a month. Meanwhile, I get maybe 2 or 3 members of that insurance company calling a week looking for services they can't find. We're also very much often told we have plenty of mental health providers on our panel. And when you look at that, few of them are doctoral level psychologists, which means that the members on that insurance company are not able to receive the services that psychologists uniquely provide, like psychological evaluations that really unlock the additional services and the treatment plan that they need. Please advance the next slide. Thank you. So this one issue that's a barrier that leads a lot of clinicians to leave the practice of psychology. Much easier to just throw up your shingle to be a life coach, completely unregulated, fee for service. This is happening. The barriers to care are created by factors which also drive psychologists out of clinical practice. And this compounds the issue of Georgia residents having fewer and fewer options for psychological care, which is magnified in rural Georgia. Please advance this slide. So I know, Representative Oliver, I'm so pleased to hear you say that the reimbursement rates are definitely a concern. They have not changed since I started practicing in 2010. I'm getting paid the same amount by the vast majority of these insurance companies. It's not a just wage. And it, in many cases, means I'm losing money
Dr.
providing
Mullen,
certain services.
I'm sensitive about our time right now. I believe you on the reimbursement issue. I'm there with you.
Thank you.
Are there any suggestions you'd like to make about the licensure procedure or credentialing procedure that is under the DCH umbrella?
Right. So what I was asked to come today is also to talk about how, even if we get through those processes, which I do think I'd like to speak to how predatory that postdoctoral experience is, because there isn't a lot of protections for the psychologists coming out of internship, maybe wanting to return to Georgia and not having a way of securing a postdoctoral situation in which that is going to bring in some income for that practice so that they can also pay a just wage to that postdoctoral resident. So what Dr. Brown was referring to, in that we can't, if I have a postdoc, I can't bill under Medicaid. And that means that there are fewer and fewer opportunities for postdocs. And of course, I take on that economic loss as a way to recruit people to rural Georgia, because it's hard to get people to move to rural Georgia. Does that resonate with kind of what you've been told before about the postdoctoral experience?
Yes, but I'm trying to figure out where our authority is in the General Assembly to fix that for you. Exactly.
Yeah. Part of it is kind of the bigger picture that I'm trying to kind of describe here, is that what has happened is that it's made it so very difficult for those of us in private practice to provide care. And so those individuals who really do want to provide clinical care are leaving the practice of mental health, which means that there's so many lost opportunities for those individuals coming out of internship to complete the process of licensure. So where do they go? They go to other states, or they don't complete licensure practice, that process. So if I could kind of just move through a couple other things here, and I can slide through. Let's see if you'll advance the slides just a couple more, please. There we go, right here. Okay. So some of the interventions that I would like, some of the suggestions I would like that would make it easier for clinicians to stay in practice and to provide those postdoctoral experiences for clinicians seeking licensure so they can complete the process, would be these kind of main four things. Greater oversight for the CMOs, because they're killing us in private practice, just not able to provide the care that's needed or really cover the cost of doing business. Greater transparency about panels, so more access to enrollment, So again, that practice barrier is eliminated and access to care is restored. Greater responsivity to patient requests for case and provider specificity. So really allowing those, and I mentioned this kind of in a previous slide, but because patients cannot choose a specialist, they cannot choose who they see because of all of these restrictions, not being able to get on a panel, then there's not a goodness of fit for that match when it comes to their care. And so they're really just not getting the care that they need. And then finally, greater transparency in setting and rate setting and recoupment. Recoupments have been plaguing psychologists. I've had some claims that have been recouped 3 times with no explanation, no notice. There's deceptive practices is basically what this amounts to. And so the business of private practice care, which is again a large portion of what psychologists do in Georgia, has become very grave and impossible. And those are the opportunities for emerging psychologists to have a start to their career and to complete that licensure process. So I'll leave it there and allow for some questions.
Thank you so much. Any questions from committee members? Thank you, ladies, for being with us today. I appreciate it. We will be continuing to follow up on many of your suggestions. I'm fairly confident. I'd like to call on Dr. Stephen Livingston at this time. Thank you
Yes.
for being with us.
Okay. My name is Dr. Steve Livingston. I have a PhD in marriage and family therapy. I'm representing the Georgia Association for Marriage and Family Therapy. I'm on their legislative advocacy committee. And specifically, I served on the composite board from 2011. I was appointed by Governor Deal to 2021 and served as the chair from 2015 to 2018. So I bring a little bit of a perspective from GAMFT and from a board member for many years. And I'm going to try to make this quick in the service of time. I know we're over, and I apologize for no PowerPoint or anything at this point. We have been soliciting input from all over, including the educational programs in Georgia, and just put this together finally last night. So let me quickly just go through and give you specific recommendations on the licensure process and the issues that we think, at least from marriage and family therapists, are relevant. First of all, in answer to Chair Oliver's your questions, there's 1,176 LMFTs in Georgia. There's 116 associate MFTs in Georgia currently. The timeline for obtaining a license is anywhere from 1 month to 3 months. It's a complicated process that involves receiving applications that we'll address in just a minute, and getting reviewed, getting voted on by the board, then being forwarded to take a national examination, which you have to register for. And for MFTs, the examination is only offered 1 week out of every month. So that adds another month to the application process. So some of the things are going to be difficult to change. Some of them actually, we have some very specific recommendations on how things could be changed. The first I want to start with is what GAMFT is doing in relation to really working on this process. And some of this we've already discovered. GAMFT is currently put together House Bill 1599 that's sponsored by Representative Alan Powell, which specifically goes to 4310A is our statute for licensure. And basically, Section 13 is the requirements for licensed marriage and family therapists. And we are working with this bill on two parts. One, the National Accreditation Body just updated their requirements in 2021, and this brings it in line, the MFT requirements in line with them. Second, it addresses what we've discussed several times today in terms of our being out of line with other states in terms of the postgraduate requirements for direction and clinical experience and supervision. And we had a work group consisting of folks from University of Georgia, Valdosta State, and Mercer, in addition to LMFTs that put this bill together. We just went through the GORC process last month and came out of there with unanimous approval to move forward and support. What the legislature can do is move this bill through once we get there, because it specifically only updates and gets us consistent with our neighboring states and other states in relation to the requirements, which will really bring down some of the barriers. So the professional organizations really are working on the statutory end to support, and bring forth bills that will do that part of this. Where the professional organizations are also setting up helplines for applicants to help them work through the application process, so that when they submit an application, the licensure board doesn't run into some problems with that. One of the biggest problems that the board has, is that when they get an application, if there's any deficiency in it, or if people haven't followed instructions and filled it out correctly, then it goes back to them, and that delays it a whole nother month, because the board only meets once a month and the statute requires that the board has to vote on each application. So the specific recommendations that we came up with: one, the marriage and family application is tremendously complicated. It's 17 to 22 pages with all kinds of things that some have to be in there still, and some can be really revised and shortened. And the board was working on that when I left in 2021. That's something that needs to really, we believe, happen, is to simplify that. That'll create less mistakes and, hopefully reduce that process to some extent. But the application needs to be revised and worked on. Second major recommendation is the development of an online application. The application is currently not online, and it goes back and forth snail mail. And, that's just a tremendous hindrance. The board's been, I know, working hard to get the approval to move to online, and I think they're in the process of that happening. But that's something that, it just, in this day and age, it needs to be an online application where, everybody can go back and forth, and if there's changes needed, they can make it. And we believe that would really help a lot. One of the things that Mr. Zimmerman referred to, and this is huge, is that the board needs more staff. I'm one of those people that was reviewing for 10 years all those applications up until last year. And I can tell you that as a board member, I put in 40 plus hours a month on top of my full-time job. And the board staff is serving, as somebody said, 7 different boards, and they haven't had any increase. And that's a huge problem for getting, applications processed. So, those two, in terms of application simplification, getting things online, supporting more board, GMFT through House Bill 1599, support from the legislature for moving that through, quickly, because all it does, for marriage and family therapy, the specific requirements are set in statute, not rule. And so it takes a legislative authority and bill to change that. And they haven't been changed in 25 years, which is creating a lot of problems for us. That's why GMFT has, got the sponsor and put this bill out there. And now, having been cleared by the GORC process, we hope that it's going to go through. This will for particularly people coming from out of state. It addresses that issue. It equalizes us with other states, brings us in line, and it gets us up to date with our accreditation body for marriage and family therapy. And we have a number of specific requirements that we don't need to talk, at least ideas that I don't need to specifically go into about how the application could be streamlined, but that'll be worked on. And then some improvement just in terms of on the board website, just in terms of frequently asked questions and things that might help people with more information so they make less mistakes on the applications. From our end, just in terms of getting people licensed, these are the things that the universities in Georgia are saying, and our membership, is pointing out as people are going through that process. And, being quite familiar with it, I'm happy to answer any questions that you guys might have at this point. And we will get you, within the next day or so, the written outline of all these recommendations.
Very, very helpful. Thank you, sir. I'm particularly interested and respectful of how much work this would be to really understand the online application improvements that could be made.
Yeah.
We'll be looking at that. So your written recommendations, like all the others, will be posted online. And
Okay.
I'm very grateful for you. Dr. Cindy, do you want to ask anything?
Yes, I just have one question. Thanks for bringing to our attention upcoming
Oh,
legislation.
I can't hear.
Sorry.
Sorry,
all right.
I'll start again. Thank you very much for bringing to our attention upcoming legislation, House Bill 1599. And of course, we're very interested in streamlining the process so that we can get individuals into the pipeline and out there doing the work that we need done. The question that I have is the recommendations that you made regarding the long application, moving from paper to online, additional support in the website assistance. Are those recommendations included in House Bill 1599?
No. 1599 specifically addresses the statutory requirements under 47-10A-13 that are the requirements to be eligible for licensure, both the educational requirements and the postgraduate clinical experience and supervision requirements. The other things are not statutory. The board can change the application without that going through statute. That's a rule requirement. And so all the other stuff that we are recommending can be done, we believe, at least without statutory authority. I mean, without changing statutes. I'm sorry.
Thanks for clarification. Appreciate
Thank you.
that.
Very helpful. Very helpful. Thank you, sir. We look forward to your written requirements. Ms.
Okay,
Mackey,
appreciate you.
we,
Thank you.
Have put you in the unenviable position of being last, but all of y'all have been so helpful that I appreciate your patience with us today. Thank you.
Thank you for having this meeting. We greatly appreciate it. My name is Gail Mackey. I'm the Executive Director of the Licensed Professional Counselors Association. I think you've heard from Mr. Zimmerman on the predicament of the level of work that the board is facing. I want to say congratulations to our lawmakers. Last year, you passed our House Bill 395, bringing the first professional counseling compact law licensure in the United States. Just this Tuesday and Wednesday, the commission had their first meeting. So we not only have the 10 states, but we went right up to 17. We're very excited because there are only 10 seats on the commission. Georgia got one. First in the United States. Very exciting. But in saying that, here is another level of work that is coming to Mr. Zimmerman's group. So not only do they oversee 7 boards, here comes more. We kindly request that at least 2 licensed analysts be hired for the healthcare position in order to handle the new behavioral analyst board and the new PC compact. There are approximately 10,000 professional counselors licensed in the state. 8,300 of them are members of LPCA. We hear a lot from them. We do 15 to 25 licensure consults a week. We have been successful in getting, I would like to talk with Voices for Children more. We have been very successful in getting those coming from overseas to get licensed. I have one woman from France. She is probably going to get her license at the next meeting. I have two from Brazil and one from Bolivia. Some of the restrictions are some places don't have a notary, but the licensing board has been flexible on working out something else. I have seen the licensing board, as long as they do get the evaluations generally we're seeing cost anywhere from $1,500 to $5,000. But if they get that review done in detail, we've seen great success at the licensing board. We've seen the licensing board also accept other types of internship during their degree program. We do know that social workers and psychologists have been around for 150 years as licensees. So for professional counselors, it's only been about 40 years. So we are impressed that their degree programs are more uniform throughout the world. We are also working on that goal, but part of the dilemma is because the profession is really fairly new, we have not been quite as uniformed as getting our educational programs across the world. But we do see that our licensing board really does try to work on helping people meet the requirements that come in that are experts in mental health come over here. So I've submitted my report, but really I just want to strongly encourage this group to really look at funding 2 more licensed analysts for the board. So if you have any questions, please let me know. We will submit a spreadsheet on licensure across the entire United States, all the rules. We do know that there are only 2 states in the US that require 2,000 hours of directed experience. Georgia requires 3,000. That's almost universal across the whole United States for counselors. So our 3,000 hours are not based on direct client contact and indirect, where many of the states do have very direct requirements on that. Ours is more open on as far as the practice. So I would like to send that spreadsheet. It will show all the different states, supervision requirements, licensure requirements, and as far as the hours, direct or indirect.
And just using that as an example, the 2,000 versus 3,000, that is a decision made by your board. That's not a decision made by the Georgia General Assembly.
That's correct.
So as we take our next step forwards on recommendations, we'll be looking at what we're going to recommend you do versus what we'll be recommending that the General Assembly might consider through appropriations. Or
we do have legislation that we will be bringing forward to continue to remove the outdated language that's in the law. We would have removed it in our House bill this session, but right at the end of February, early March, we were told early on we wouldn't have to go through GORC, but then we were told we would if we removed all these expired sections. So we went ahead and left them in, but we will be back to kindly ask y'all to remove all those expired exemptions.
and finally, for the benefit of the world watching, what is GORC? So you tell us what that is.
That is a government agency that reviews each piece of legislation in reference to how it might affect the business and the population.
Thank you so much. It's an important entity for our consideration. Thank you, everybody, for your patience today. I'm very grateful for your attendance, and we will be in further touch as we move forward. Thank you very much.
Thank you.